movement disorder. Some detail we know in the morning session already. And I would like to recap again for the definition of the tremor is the rhythmical sinusoidal oscillation movement, which is the oscillation is one of the key of the definition of the tremor. And also I would like to emphasize again, tremor is the most common form of involuntary movement disorder in adults. And we can classify into rest and action can be classified into kinetic and also postural and isometric. The kinetic is the tremor occur when we have an activity, and we can test with like the finger to nose test. The simple kinetic is the tremor that occur or the distance from the beginning to the end point. And intention, like we see in the cerebellar dysfunction, at there you will see the tremor at the end of the target, and also some task specific. For the postural is also position dependent and independent. Another one is the isometric tremor, which is you won't see the movement in the glass, but actually your muscle as contraction, like you hold the grass or the bottom of water, you didn't move your arm, but your muscle also contract and have a tremor. This is called the isometric tremor. And a little bit tip for the tremor examination according to the body part. For the rest tremor, I usually I already talked in the morning. And the second is for the postural. First, you ask the patient to extend the patient arms in the outreach position in the pronate, and then ask them for supinate. And then maybe you ask them to perform like a bend of the elbow, like a wing beating position. And for the evidence of the kinetic or intention tremor, you perform the finger to nose test. But the key is you have to ask the patient to reach to the end of the distance of the patient arm to see all the component of the kinetic tremor. And also you have to look for other features like dystonic posturing, another co-assist Parkinsonism, and also cerebellar side that also quite common to occur together with the tremor. And this is for the history taking scope that can lead you to the tremor consensus that we will talk later. You might get from the history like the part of the body that have tremor, how long did you notice it, or under the circumstance like action or rest, and where is the tremor spread, what the temporal cause of the tremor, is its impact your physical or social or not, and do you have other neurological or systemic condition or other medical use or family history. As I talked in the morning, from the tremor consensus in 2018, we classify into two axes. The axis one also the clinical characteristic, and the axis two also etiology, like in dystonia classification. And this is different from dystonia a little bit. For the axis one of the tremor, you should get the history feature like age of onset, temporal onset, alcohol drinking, and the sensitivity of the alcohol and drug, and also the past history, family history. And you have to get the tremor classification like body distribution, activation, or frequency that you have to notice. And another one like you have to know the associated side, like other neurological or systemic side. And the last one, the additional laboratory test, for example, the electrophysiological test. And the axis two also etiology, which is usually acquired and genetic, and also maybe idiopathic, familial, or sporadic. And when you get the information from the axis 1, and then you can group or summarize into the tremor syndrome. For example, the action and rest tremor are the predominant side in the essential tremor or essential tremor plus, or either enhanced physiological tremor that I cannot go deeply into every tremor syndrome. And the second one might be focal tremor. The third one is task-specific tremor. The next one might be orthostatic tremor. And you have to look for the tremor with prominent additional sign or other. So I recap this video again for the tip of the examination of the essential tremor patient, or might be the prominent postural or kinetic tremor. You not only perform the tremor test with only the postural or kinetic. Another effective or quite good test is handwriting. In the severe essential tremor, they like illegible handwriting in or the big one with the shaky characteristic. Or you can test patient to water pouring to test their capability, and the water usually spread out from the grasses. And you can use the Archimedes spiral drawing. It is usually the axis of the tremor amplitude, like the 60 degree in the case of essential tremor. It's easily that you can spot the shaking of the tremor on the spiral. Okay, let's move to the next video. And I will ask you what is the diagnosis in this patient. If anyone want to volunteer to guess the diagnosis, please raise your hand. As you will see that he has a rhythmic oscillation when he used of his hand when he used the scissor. But in another test, he can perform it perfectly. And this is the task-specific tremor, which has several forms of the tremor depend on the situation. The primary writing tremor is the most common form of the task-specific tremor, but the tremor can occur in the patient who specialize in motor skill and practice over and over and using this body part repetitively. For example, the musician, the golfer, and scissor, like in this patient. And the next case, I have the answer. He is the 15 years old boy with a history of right little finger tremor. He only complained of this tremor on his little finger for 3 months. He also has a normal cognitive and mood, normal perinatal history, no family history. But on the examination, apart from the tremor that you see in this video, we found a little bit very mild rigidity on the right arm. And for the eye examination, you will see the yellowish or grayish in the upper limbus of this patient, which is the KF ring. And the serum ceruloplasmin is quite low, around 1 to 2. And his diagnosis is the Wilson disease. So, another rare tremor syndrome is, you will see in this patient, he in the position of the wing beating, like the bend of your elbow and stretch your arm. And the tremor is quite high amplitude. in the proximal distribution of the arm. This is the wing beating tremor, which is we can see in this tremor in Wilson disease too, but not all of the Wilson disease patients need to have this tremor. So let's move to another part of the tremor, like neck and legs. For the neck tremor, it might be in the direction of no, no, yes, yes, or in multi-direction. And you have to look for the maybe subtle dystonic posturing like an torticollis or the shoulder elevation, apart from the examination. That will be maybe more prominent when you see the patient when they're walking, and their subtle dystonia will be more elicit. For the leg tremor, it can be classified into rest tremor, that you have to ensure that the foot of the patient flat on the ground to be the true resting. You have to support the body part that you have to test, because if it didn't flat on the ground, it might be when the patient extend the ankle, it might be the cronus that you see, like the rhythmic movement. And for the postural tremor, you can ask patient to walk or no, not to walk, to stretching out his or her leg or standing. And the last one is observe the tremor when the patient walk. So, and you see the 60 years old woman, she complained of the leg tremor for 1 year on her left leg like this. Actually, her foot didn't press to the ground for the whole of her foot, but she has the tremor. As you will see the rhythmic oscillation in side by side. And when I try to press her foot on the ground, the tremor decreased, but still have a little bit tremor. When in the third, and for the bradykinesia, I think she also have a little bit bradykinesia on the left side. This is the toe tap. At the beginning, when I saw the first video that my friend sent to me, I'm not sure this is the real to resting tremor or not, and then try to do many positions. Another, apart from the my bradykinesia, she also have a rigidity on the left side. So I tried levodopa in this patient, and she returned with maybe 50% of the clinical response. So let's move to the leg tremor. For the rest tremor of the leg, you should think about the Parkinson's disease or another dystonic tremor that can cause the tremor on top of the dystonia. And another mimic might be cronus that you have to keep in mind. For the standing, most common is the orthostatic tremor. For the fast frequency, is around 13 to 18 hertz. It usually is called the characteristic of the idiopathic orthostatic tremor, and sometimes it associates with other neurological disorder like Parkinson's disease. It's called OT+. And for the slow frequency, like less than 10, it usually associates with other neurological disorder more common than the fast frequency. And for the walking tremor, it's quite very uncommon. Maybe some part with the cerebral disease, with maybe often with the truncal dystonia, and sometimes the walking tremor should consider for the non-tremor cause like myoclonus or another like functional movement disorder. Okay, and this patient, you will see that she has an abnormal posture on her neck with a tremor on top. And sometimes tremor when on her hand. She is the dystonic tremor, which is a spontaneously oscillation, rhythmical, and although often inconsistency pattern movement produced by contraction of the dystonic muscle and maybe exacerbated by the attempt to maintain in the primary posture. This is the comparison for the essential tremor, Parkinsonian tremor, and also dystonic tremor. Let's move to the next one. Which, after you see the video, which one do you think has the essential and which one do you think has a symptomatic? Okay. For the first patient, you will see the rhythmic movement of the whole palate. And if you carefully listen, you will hear the ear click sound. It's like click, click, click. It's very small. And sometimes he can stop the movement. The first patient is the essential palatal tremor, but in the second patient is you not only see the palatal tremor, but also have a tongue tremor and also have another neurological sign like a tongue deviation. Is the symptomatic palatal tremor with the lesion in the brainstem. So what is the palatal tremor? This is the rhythmic movement of the palate, and it can subdivide into essential and symptomatic. For the essential tremor in the patient, number one is the absence of the region, and you will find in some patient with voluntary movement in the essential palatal tremor. And this muscle that affect is the tensor villi palatini, the insertion of this muscle insert at the eustachian tube, so you can hear the ear click in the essential palatal tremor. And for the symptomatic palatal tremor in the second patient, it usually have the lesion in the brainstem in area of Guillain-Barré triangle, with include the red nucleus, olivary nucleus, and also dentate nucleus. And is the muscle that involved in the different muscle from the essential tremor, so you didn't hear the ear click in the symptomatic palatal tremor. And this is another cranial tremor. For the tremor examination, you have to keep in mind there might be other tremor mimics. For example, cortical tremor, which is actually the cortical myoclonus, that quite rhythmic. that can be found in familial or idiopathic, maybe in MSA. The another one is the atetosis. The atetosis is the distal hand dystonic posture and also in choreiform movement, but sometimes it can manifest like rhythmic, so it might be confused with the tremor. And another one that I mentioned is the cronus. For the dystonia, as the sustained or intermittent muscle contraction that cause abnormal posture and repetitive movement and posture. Again, I will show you the generalized dystonia patient, which is involuntary, relatively sustained or intermittent muscle contraction, and usually produce the twitching that you will see that in her neck, her arm, and her trunk, which is the twitching and repetitive of the movement with an abnormal posture. This patient is the generalized dystonia from the cerebral palsy, from the birth asphyxia. This cerebral palsy can cause the delayed dystonia. Apart from the abnormal posture, other phenomenology or signs that we should look for in the dystonia patient, like for example, the outlying spasm, muscle hypertrophy, the directional preponderance, the variety of dystonia with the changing of the position. And usually dystonia increase with the voluntary movement. And sometimes it worsen with the stress and fatigue. And sometimes it improves during sleep. For the cervical dystonia, sometimes we will see the interesting sign. This is called sensory trick. You will see this severe cervical dystonia patient. And he said that he just touched his nose or his face, and then the position can be collected. And this is called sensory trick or jest antagonist, which is the voluntary action like tactile or proprioceptive that correct the abnormal posture or abbreviate the dystonia. And sometimes imaginary sensory trick can also be effective. And again, this is the dystonia tremor that we around the tremor can fall together with the dystonia. And this one is the example of the writer cramp patient, which is one of the task-specific dystonia. She didn't have any dystonic position in every situation except for when she start to write. You see that her arm is spread, and then the abnormal posture overflow to the elbow and sometimes to the shoulder, which is called the overflow of muscle contraction. And when you ask her to write in the left hand, and you notice on the right hand that has elicit the dystonic posture, which is the Miller dystonia. Okay. Again, for the axis of the dystonia in order, axis 1 and 2, like I mentioned in the morning. Okay, let's to next patient. She is the 40-year-old female and feel like her leg is contract and has an abnormal posture when walking, usually in the evening for 4 months. And she has normal walking in the morning. Other no pain, no weakness. She has doctor with no normal cognitive and no other past medical condition. And she has a family history of her grandfather suspect diagnosis of Parkinson's disease at the age of 80 years old. You will see a little bit abnormal posture on her left leg, very mild, like the internal rotation of her ankle. And sometimes it looks like she has weakness on her left leg, but actually we test the weakness. She has no weakness. For the diagnosis of this patient, she has a DOPA responsive dystonia with the prominent feature of dystonia and Parkinsonism, and also have a diurnal variation. The onset usually in the childhood in the classic GCH1 mutation, but maybe adolescent or adult in another mutation. And it's for the GCH1 mutation is inherited in the AD inheritance. This is the rate limit. The mutation is affect the rate limiting step for the theta hydrobiopterin, which is the pathway of the dopaminergic mechanism synthesis. So, and the treatment is just the low dose of the levodopa, and one of the characteristics of the dopa responsive dystonia is the sustained response to low dose levodopa without the motor complication in the most classic DRD. But now we have many genes that causing the DRD that were found, not only GCH1 mutation, and making the clinical presentation of the DRD is quite varied. For the chorea, this is the irregular, flowing, and non-stereotype, random, and of involuntary movement. Again, chorea is quite random. So the examination of the chorea, you have to look for the phenomenology that I mentioned. And sometimes it might be very mild that resemble like an only restlessness. And for the proximal and large amplitude, this is the balism that I show you in the morning. And sometimes chorea can worsen by anxiety and stress. This is the two patients. The first one I show you in the morning with the Huntington disease. And the second one also have a very mild chorea than the left one. You will see that she have an irregular flow of light in her finger, her foot, sometimes in her face. She also was confirmed of Huntington disease too. So it might be the spectrum of the one disease. Another is the parakinesia.
This patient with HD. Generalized.
He also a Huntington disease patient and have a generalized chorea, but you will see that he frequently touch his glasses, his mouth, or any part of the body. This is called parakinesia. This is voluntary or semi-voluntary movement, such as touching the face or adjusting some part of the body to hide his chorea. This is called parakinesia. Another interesting examination for the chorea, for the Huntington and sometimes found in Sydenham chorea, is called hung-up reflex. This patient has a Huntington disease, and when you perform the knee jerk, you will see the delayed relaxation of the knee, which is the hung-up reflex that can be found in Huntington disease and sometimes in Sydenham chorea. For the examination step for the chorea, you have to look for the feature to exclude other like pseudoathetosis, which can be look like chorea, but it is from the impairment of the proprioception. It may be more severe when the patient close their eye and impair the proprioception test. And then you can determine the distribution of the chorea and try to find the other side. And this is the huge risk of chorea, cause of chorea. Maybe you can divide into hereditary or acquired, and then you find another possible cause. The cause of chorea is usually from the general medical condition like SLE or metabolic disorder. And the next one, you will see chorea on her right hand, which is the hemichorea. That you keep in mind that hemi lesion, you might think about the contralateral structural lesion, or maybe some metabolic like non-ketotic hyperglycemic chorea. But the answer of this patient will be in the next session. Okay, let's move to the myoclonus, which is the brief, intermittent shock light and jerk light. You have to identify this is the true myoclonus. Myoclonus is negative or positive. And what are the clinical characteristics of the myoclonus and anatomical and etiology? You have to keep in mind that myoclonus is the clinical sign, is not the diagnosis. Again, I would like to recap for the classification according to the clinical classification and physiological classification. So this is the example of the cortical myoclonus, which is usually in the distribution of the distal limb and action induced. This patient have a hepatic encephalopathy when he stretched out his arm like this, and then have a postural lap, which is called the negative myoclonus. Or you might be sometimes, like hysteresis, I can't remember. And for the subcortical myoclonus, the distribution is goes to your axial and your body. In this patient, it's quite common for the consultation from the medical department, like after he has the cardiac arrest, and then you can resuscitate our ROSC. And after that, this patient develops the jerky movement like this. It's usually generalized multifocal myoclonus, maybe predominantly axial and sometimes proximal part of the arm and leg. And this is the post-hypoxic myoclonus, which is the poor prognosis in the patient with cardiac arrest. They have two forms of the post-cardiac arrest myoclonus. The previous one is the immediately form. The next one is the delay form, which can cause the axial myoclonus and sometimes with a little bit intention limb myoclonus, but the axial is prominent. It's called the Lance-Adams syndrome. The patient usually has the like bouncing gait, as I show you. He also have a stimulus sensitive myoclonus too. And the myoclonus predominantly in the axial. All right. It's very difficult to stand Oh. So again, this is the distinct feature of the hyperkinetic and the examination. To the last one, I show you in the morning, this is the functional movement disorder, and also in this patient. He also has a tremor on his right leg, and waxing and waning, and sometimes it's distractible when he perform another volitional movement. Yes. For the functional movement disorder, the clinical clue might be acute onset, waxing and waning, changing in movement over time, and maybe can migrate from one part to another part, and maybe absent of the should be his sign in the circumstance disorder, and maybe have a history of psychiatric disorder, and maybe get a secondary gain. For the examination, it might be different tests to perform. For example, the distraction with the movement can disappear when with the distraction that I will show you in the next video, and reappear again when the nothing to focus. And the movement can vary in the frequency and entrainable. Sometimes fake dystonia might be one of the suggesting feature of the functional movement disorder. For this patient, she has a functional movement of tremor on her right hand.
I'm sorry, Dr. Sringan, we had overtime, so you can speed up. Thank you.
Yes, thank you. And this is the distractible. We asked her to perform the hand open and close, and the tremor is disappear. And this is the entrainment. We asked her to perform the rhythmic movement, and the frequency of the functional side will follow the same tremor as the voluntary side. Like this is essential tremor, as entrainment, sorry. And this is the list of another possible functional tremor. And this also take-home message to examine the hyperkinetic to find the prominent feature, look for the mimics, and also be careful for the diagnosis of the functional movement disorder. Also, thank you.
Thank you very much, Dr. Girada. Very excellent.